so what out there when we, talk about why to take action, for example, against burnout, which is just one manifestation of chronic work stress, is that we know it's associated with medical error and malpractice. We know it leads to job turnover and people cutting back on their work hours, which impacts, people's access to care. We know it impacts quality, safety, but also professionalism in the different ways that we think about cost-conscious care. We also know that burnout sort of brings out the worst in us with respect to our racial bias, and that it costs the healthcare system, billions of dollars in the United States every year. And even within an employer, it costs really a lot of money, up to $7,600 per year per physician, that's directly attributable to burnout. So we know that we can't have successful healthcare reform if we don't pay attention to the well-being really of our workforce. And then beyond the business case, there's obviously the moral imperative, which you all are very familiar with. And I think that the recent suicide of the physician in New York really sort of brought out into, again, the attention of the lay press, this problem of suicide in healthcare professionals. And particularly women physicians are much more likely to die by suicide than other women in the population. So again, pre-COVID, we had leaders across academic medicine. Victor Zhao is the head of the National Academy of Medicine. Daryl Kurt was at the time the head of the AAMC, and Tom Naska is the head of the ACGME, really saying that we have a crisis and we need to collectively confront this crisis. And of course, we all know that this crisis is now really so much worse in our current COVID environment. So how do we go about sort of supporting, from a system perspective, healthcare workers? And I think that's sort of really the crust of my time with you, is to thinking about and talking about what have we done at Mayo, why have we done it, and what do we see sort of as opportunities moving forward. And from the beginning, our big framework for supporting our healthcare workers was really to think back to old public health, frameworks of primary, secondary, and tertiary prevention strategies. It's really being the foundation. And then as we think about supporting our staff, again, to think about, okay, we need to really think about all the different types of workers that we have, which I mentioned before. But within these groups, we have workers who have really high coping reserves, but we also have workers who already were really struggling. We have workers who, we send home to quarantine and they live alone. We have workers who don't have VPN access. We have workers, in research, education, and practice, for examples. And we have workers, obviously, across multiple different states. And then as we thought about how to support them, we often think about emotional and mental health, but there's obviously lots of other domains of well-being that we needed to think about. And then, what are the different strategies really that we can employ? So to give you a couple really concrete examples of what we have been doing at Mayo, one thing is sort of leveraging a new listing strategy. So we started a Facebook site that was sort of invite only. You have to be a Mayo employee. There's different ones for our different sites, to really give people an opportunity in a new way to create connections and also to stay connected with one another. And you'll see very simple things on the Facebook Connect. Some of it is like, crap, where can I park today? But other things are much more like people will put little piano pieces that they've crafted, really sort of inspirational and community building. We've also recognized that we can't just put all our well-being resources behind our firewall. That doesn't work for some of our, certainly for our furloughed staff who don't have VPN access. So we created a We Are Mayo Clinic sort of external website that enabled people who didn't have VPN access really to stay connected, to access resources, and also to continue in their own professional development. We very quickly sort of ramped up new learning opportunities for people to, engage in asynchronous academic and otherwise career development to strengthen their knowledge and skills. We have a very active Healthy Living Center at Mayo Clinic. And okay, so you have all these health coaches and you have, fitness instructors, and what do you do with them, right? Well, you make them put their content online, whether it's synchronous or asynchronous. And we were able to really sort of galvanize that community. And we actually have a lot of participants among our employees to participate in various fitness activities and other experiences that the Healthy Living Center typically runs. We've also launched a huge campaign around psychological first aid training, and have had nearly 1,000 of our employees sort of just volunteer and take that to help build some of their own capacity. So parts of it in our approach has been, like many of you, really this sort of asynchronous, okay, click on this website and get this skill, or use Facebook and connect with somebody. But in addition to that, we also wanted to really create synchronous experiences, opportunities for people to connect. And that was another important part of our strategy, where people would have to, participate at a certain time in order to connect with colleagues or build certain skills. What you see here on the slides is some of the sort of hits, or how much people are using this. So you can see, for example, in this well-being newsletter that got sent out, that 23,000 people are at least sort of looking at it. Whether or not they're sort of clicking further into the newsletter, it's a much smaller hit, but you get a lot of content just from opening up the initial newsletter. You also see some of what are people interested in with furloughs and those sorts of things, and salary reduction. It makes sense that there are a lot of hits on sort of the articles that related to financial resources. But you also see hits on other sort of things that we were pushing out around resilience and staying connected and supporting our staff, which I will tell you a little bit about in a minute. Another piece of our push was to get people to recognize that they should self-assess their level of well-being. I think we're all under enormous amount of stress, and our research has shown that even physicians who diagnose all day long, we're actually really bad at self-diagnosing or self-assessing where we are on sort of that well-being continuum. So we really pushed out, encouraged people to use the well-being index as a way to sort of self-assess their level of distress, track it over time as sort of the months have passed on, and then to also be able to, outside the firewall, get immediate access to resources that are tailored just for them. Like many organizations, we have different resources available for different job categories and also for people at different sites. So rather than sending everybody to one generic website where half the stuff doesn't apply to you, we were really able to tailor things based on where people work and what people's job code was. So that it was really simple to say, okay, this is for me, and this is how I can get it. And this is sort of how I'm doing with respect to my mental health and emotional well-being using a validated instrument. So that's been a part of our effort as well. In terms of building virtual social connections, we have what's called well-being connection groups. So this is part of that synchronous component that I talked about. And there's a variety of different topics that are facilitated by our wellness coaches, whether it's around self-compassion or managing furlough, or some of the nuts and bolts of teleworking, all the way to emotional health. And these have been really very successful, mostly among our allied health staff, so our non-physician staff. Our physician staff, for their social connections, have really been relying a lot on Compass groups. So several years ago, Colin West, one of my colleagues, did a randomized control study using these small groups people got into, physicians got into. They were given a topic to talk about. They had a meal. It's really about building social support and connection. And in the randomized control study, it was really proven to have a positive impact on people's well-being and satisfaction with work, connection with colleagues, those sorts of things. So we've had a long-standing history of having these Compass groups at Mayo with over 1,900 physicians and scientists participating. Well, that works great until you get COVID, right? And people can't, dine together. So we have switched them to virtual COVID, or virtual Compass groups. And it also provides an opportunity for us to support some of the restaurant takeout services in Rochester. So people are still getting their meals reimbursed, and then are, bringing them in front of their laptop and having a Zoom meeting with their colleagues. And then, they're all eating different foods from restaurants from around Rochester. the physicians could also choose not to have their meal reimbursed, and then that money we actually would put in a special account that we have for our employees who are undergoing significant financial stress, and they can, you know, get some money out of that pot of money. So it's also a way for the physicians sort of to help out the allied health staff from that perspective. So these are just some of the ways that we've been building social connections. We've also done just a push of just kind of making people aware of what's been going on. So Dr. West and I gave grand rounds at Mayo not too long ago, and we had sort of solicited input from all of our colleagues in the department saying, okay, what are you doing? And really just sort of advertising that. Again, you know, showing the strength of Mayo, telling people a little bit about, you know, what other people are up to. And I think it's been really a unique opportunity to showcase some of the activities that have been going on, like Zooming with friends, etc. But that's really, again, sort of the generic approach, some of the things that we've been doing for all of our employees. And I just want to spend a few minutes talking about what we've been doing for our COVID-19 frontline workers. So one thing that our chaplains actually started was SOS care packages. So it's a really pretty simple idea. We were able to gather a variety of things, whether it's toiletries, chocolates, you know, just sort of anything that you can think about as a nice little gift or treat that was inexpensive, that we would then bring to frontline workers. This could be the COVID screening clinic, the respiratory clinic, the ICU, the emergency room, but we also brought it to telephone operators, to the security staff, to the janitorial staff, just little care packages, thanking them for their service, thanking them for their dedication. And we really got, you know, I think that it was a really good way to sort of help people feel appreciated. We had the sort of, in addition to sort of giving you this chocolate or this care package, we're also going to give you this little piece of paper that tells you, you know, how can you get help? What's the phone number for the warm line? How do you connect with EAP? How do you connect with behavioral health? What are some of the online mindfulness programs? So we had sort of a little bit of a backdoor agenda in terms of helping them connect to some of the resources that we were making. But these SOS care packages really have been very well received by the staff. The other thing that our emergency room created was a going home checklist. And this was really just a way to sort of think about and decompress your day, what went well, what didn't go so well, who could you reach out to, what are some of the ways you can sort of separate your work life from your home life, you know, what do you feel personally you need to do in order to walk safely into your home, these sorts of steps, and that was something that we were able really to push out. We also, because of sort of changes to the volume in the hospitals, established quiet rooms that were close to the ICU, close to the emergency room, in the COVID clinic, where people could just go and, you know, decompress for these frontline workers that again would have, you know, resources available to them. The chaplains and other people wanted to do rounds in these rooms, and while we thought that would be great, it kind of violated some of our, you know, social distancing, minimize the number of people who are in the hospital, all those sorts of strategies. So we had to say no to that piece, but, you know, do provide resources and things within these quiet rooms. But one of our cautions in this work was we didn't want to put it all on the person. Right? We wanted to really think apart about kind of what could the system do, and that's where the remote expediator comes up. So for our hospitalist in Rochester, they have clinical assistants who basically round with them, who will hold their pager during critical conversations, who will, you know, help with some of the clerical tasks, make sure there's a primary care doctor assigned, you know, put some of the orders into the computer, you know, make sure people are signed up for the portal, you know, a variety of really clerical tasks. And as our physicians in the health system were really starting to get high volume of patients due to COVID, you know, we wanted to be able to bring them more support. But we couldn't build the team. They didn't want more people exposed to COVID. So we built what we called remote expediators. So basically the hospitalist in the health system got a very fancy iPad, and rounded with the clinical assistant who was sitting in Rochester. So the clinical assistant would sit in Rochester, come along on rounds really in an iPad, and we're able to do a lot of the clerical tasks and support for the hospitalist who was working in the very busy setting out in the health system. And this is actually something that we plan to continue and to build. We think it's a great sort of new normal way for us to help provide some more support for our frontline clinicians without in areas where we don't necessarily have the workforce, by offering more opportunities for people to telework, even in these more clinical capacities. Another initiative that we rolled out is called Healing the Emotional Lives of Peers. So Healing the Emotional Lives of Peers, or the HELP program, is a peer support program that's been around in our anesthesia and OB area in Rochester for quite some time. It's really built as a way to support colleagues who may experience an adverse event. So it is designed to help minimize the risk of second victim phenomenon, but it's never been able to grow. So it's always sort of just been in these little niche areas, and we said, why is it in these niche areas? We need this in the emergency room, we need this in the ICU, we need this on the chest service. So we really were able to grow this across the enterprise, really outside of Rochester even. We enable, rather than having a face-to-face training to be a peer supporter, we were able to develop a web-based training. We have to date trained 87 physicians, 19 advanced practice providers, 50-some nurses, and allied health staff. And the feedback that we've gotten from people who've gone through the training has universally been outstanding. You know, I'm always a little nervous when I get a call from a psychiatrist or a psychologist who's like, you know, super expert in this area, and they want to talk to me about the HELP program or the training they received, and I'm like, oh no, you know, what happened or what are we doing wrong? And universally, I've been relieved and just you know, so impressed by their level of support, their sponsorship, and their positive feedback. We have a nurse anesthetist, a woman nurse anesthetist, Robin, this is her baby, this is her program, and she's just doing an outstanding job. We feel very lucky to have her, and are building out a train the trainer program and the rest of it, and really hope to continue to expand the HELP program as one way that we can, you know, really support our colleagues. So that's something that we've been moving forward with. One of the big black boxes, and I'd love to hear your experiences in this area, is to try to figure out how to support the Mayo family. So what I'm talking about here is people who are in quarantine, whether that's because of a work-related exposure back, you know, when that was happening, or community-related exposure, which is certainly happening now. But what do people need? You know, they go into this black box when they're quarantined because of all the various rules. No one is able to tell me or my staff who's been sent in quarantine. But what we were able to do is to get a link to a survey that is then sent to everybody, all employees who are put into quarantine, just to very simply ask them, you know, what's their experience in quarantine? What do they need? Are they getting sort of what they need from public health and from Mayo? Are there other things that they need? And that's been a really interesting insight. Recently, one of the things that we have learned from our survey is that our colleagues are experiencing a little bit of stigma. And we have a big campaign now at Mayo about lead by example. You know, do your part, you know, wash your hands at work and at home, you know, wear your mask at work and outside of work, you know, and it's a really great campaign, but it's having a little bit of an unintended negative effect in that people who do get COVID, rather it's a lapse in personal judgment or just bad luck, that there's some stigma, that they're getting quite a bit of negative feedback from supervisors. They're getting, they're worried about their job security. So it's been a great way for us to have a listening strategy to say, okay, this campaign around responsibility is a great one. And we have to be careful that we're not unintentionally, you know, building stigma that in any way could get in the way of people getting tested for COVID or going into quarantine because they should be. So that's been a great listening strategy for us. You're probably aware of the warm line. I think we stole that idea from you, for many of you who were doing this. In addition to the warm line, we were also pushing out, other mental health services that we learned about through this collaborative and others. We have sunsetted our warm line. We weren't getting very many calls in the last couple of months, so now we have transitioned back to sort of the normal kind of EAP, integrated behavioral health, primary care processes. But I'd love to hear if others are getting still lots of action on their warm line. And then in the last bit, I just want to talk a little bit about our bereavement response plan. So early on in the pandemic, it became clear to us that we actually had no institutional policies or procedures or toolkits in the event of a death of an employee from anything, whether it was COVID related or not COVID related. And to us, that seemed like really a huge gap, because we wanted to be able to support our work unit leader. We need to support our work unit leader. We need to have a clear process so that people know, what should they do? How should they do it? How do they help a grieving community heal? And in the situation of COVID, how do we reduce the risk of employee abandonment, which is something that can occur, has occurred certainly in nursing homes in the United States during the Ebola crisis, was a huge issue abroad, and something that we wanted to be prepared for, sort of in worst case scenario. So our bereavement response plan is really a toolkit to help support supervisors. And it outlines the process for what to do if a death is work-related. Turns out there is a requirement around reporting work-related death within 6 hours or something like that. How do you sort of think about the processes and the procedures if an employee died while they were a patient at Mayo Clinic? There are different things to think about if an employee died somewhere outside of Mayo Clinic. And then if you learn about the death of an employee, who do you notify? How do you notify them? Do you notify them in the middle of the night? Does the CEO need to know? In which situation does the CEO need to know? Do you call the CEO? Do you call legal? What do you do? We were thinking obviously about a high-profile death related to COVID, but there's lots of other situations. We of course recognize the importance of if there were to be a death by suicide, for example, which can happen during a pandemic due to the increased stress, to also really make sure that we had a process in place for that in no way could cause contagion in our learners, for example. So really thinking about that piece. And although the physician and care team involved in the employee would obviously be reaching out to the family, a chair of a division or department often has a relationship with the employee and the employee's family. So how do you reach out to the employee's family? How do you share the news? Who do you share it with? How do you share it? Do you send an email to the division that, so-and-so died? Or do you call them all together and have a Zoom meeting to talk about it? How do you do that? When do you do that? What are some of the best practices around it? And then also thinking about memorialization, how that could set a precedent, that all deaths really need to be treated in the same way so that you don't unintentionally, fuel stigma. And now with social media, how do you deal with that? If there were to be a death related to COVID, for example, of a healthcare professional at Mayo, how do you deal with the social media piece of it? And we work hard with public relations to also get scripts prepared in advance so that we wouldn't have a last minute panic, but rather would have, okay, this is what we prepared. Does it still make sense today? And then, use those scripts to support our supervisors or chairs, as well as the rest of the team. This turned out to be a lot. So we built with them a bereavement response support team. So this is really a team that knows these processes well. There's a member from chaplaincy, from employee assistance program, from psychology and psychiatry, from public relations, and they can be activated through the operator. So if you learn of a death, of an employee, you need some help navigating how to do this correctly, you just call one number, the main Mayo Clinic number. It then activates the bereavement response team, who will then contact you and help you through this process. It's at the discretion of the leader whether or not to activate the bereavement response support team. Obviously, emeriti can pass away from a long-standing chronic disease that's very different than sudden unexpected death, whether it's COVID related or not. So that's our bereavement response plan, which has had input from over 17 groups and has been through numerous committee meetings and endorsement processes. And now we're in that process of really making sure not only the physician sort of department chairs know about this, but also our supervisors know about this for the allied health staff, so that we really can help support them. Of course, we hope that we never have to use it, but of course the reality is that in some capacity it will likely be used. And then I just want to end with, I think we're all having, a bit of uncertainty fatigue, caution fatigue, and the rest of it in the COVID environment. And I think it's easy to sort of blame the person a little bit. And it's really important for us to focus on, what can the system do to provide support, but also what can the system do in the current environment to innovate? Is there sort of an opportunity to really address some of the underlying factors contributing to burnout and other work-related issues that were there before COVID? Can we come out of this on the other end somehow better, stronger, with more efficient, better systems? And that's really where we continue to rely on the National Academy of Medicine consensus report, Taking Action Against Clinician Burnout, to really give us a lens to think about system-based approaches to professional well-being, recognizing it's a really complex problem, but there is an opportunity here, for example, to think about telehealth and flexibility, and how could that look like going forward in a way that benefits patients as well as really as well as the clinician. How can we sort of optimize work demands and work resources in a way that could reduce all of our work stress, so that we could thrive more going forward. And I think that's that's our challenge as sort of system change agents, to think about how can we do more human-centered design processes, so that as we learn through this phase, as we move forward, COVID and beyond, how can we at the end of it really have co-design better solutions for patients and clinicians. So I think that that's probably, I just want to make sure that we really have enough time for questions. So we can talk about some of the components moving forward if people would like to do that, but I really want to make sure that we have time to engage in dialogue, and I welcome you to contact me as well, either through Twitter or email as well. So I'll stop with that, and Jody or Tanny, or if others want to speak up.
Yeah, thank you. That was fantastic. When I originally reached out to Dr. Dyrbye, it was around the bereavement policy that I heard about, and then we started talking. I said, well, tell me what else you're doing. And so she told me about all these great things, and she said, well, what would you like me to present on? I said, all of it. So I didn't give her an easy task, but that was a really great summary. I have some questions. I'd encourage you all to chat in more about things that you want to know specifically about. I will kick off and just say, what have you been surprised by, both maybe positively or maybe less positively, in terms of the programs? What's been interesting for you as you've gone through the past several months?
Yeah, I mean, I think I think one of the things that early on, we were really sort of in this crisis mode of pushing out a lot of resources. And I don't think we were as reflective of the concept that we had so many different, we treated everybody as if they were a COVID-19 frontline worker, and I think that was maybe a mistake, because a lot of what we did was really applicable to the emergency room and to certain groups of physicians. I'm a primary care doctor. It was relevant to me. But it wasn't relevant to everybody. And I think that was really a learning opportunity for us to think about, oh, wait, we have people who have nothing to do. Wow, that was really a news flash. How can we help them maintain meaning and purpose and feel good about themselves and build their coping capacity use this opportunity to advance in whatever way. And I think that was really kind of an eye-opening experience. We can't just have a blanketed approach for all, 65,000 employees and think we're doing a great job.
Great, thank you. Tanya, you want to be in charge of that?
Yeah, one of the questions that we have here from Sandra is, how is your warm line different from the EAP? I know you said that you were had decided to discontinue the warm line, but was there a difference?
Yeah, so the warm line was actually staffed by some of the nurses in psychiatry. So, they could sort of provide an immediate ear just to listen if somebody kind of wanted to just vent about their experience or their challenges that day or their current struggle. Versus if you call the EAP line, it's more of a triage system to get an appointment. Although when you called the warm line, there would be a little bit of sort of subtle triage, like, can I handle this on the fly in the moment in the course of, a few minutes? Or is this something that I need to sort of, talk the person down and give them some resources, whether it's, some telephone numbers or warm handover to the EAP triage line, or, so the needs were really very different. The warm line provided an opportunity also for people who were just socially isolated, who were home on quarantine, just to call and talk to somebody. They didn't necessarily have an agenda of, I need an appointment with EAP, right? So it did fill a need, and it got quite a few calls, particularly like in March, but then it's tapered back down again. So EAP remains, the number that we're pushing out to people in the current environment.
And then you have the HELP program as well. So how does that fit in that context of an EAP? Do people reach folks from
so the HELP program really is focused on, for example, you're in the ICU, you're taking care of a COVID patient, and you've been working with this patient for 2 weeks and they die. And they're young and they're healthy and you're traumatized.
Okay.
And yeah, you might need EAP, if this is a prolonged thing, but what you really need in the moment is someone who's had experiences like you, who sits with you and has a coffee cup conversation, right? It's more that immediate peer support. The HELP peer supporters, they are, they know that they're not mental health professionals. They are peer supporters, and they have, this is the number for EAP. This is the number for, primary care. Did you know they have integrated behavioral health? They know how to access resources for people who seem to have more of a, might have more of a prolonged issue, but it is more in the moment peer support. The goal of HELP is to have that coffee cup conversation within 72 hours, if not immediately, as much as as possible.
So I'd like to ask more about the well-being index. So just for those who are interested and want to check it out, are the resources kind of curated by each organization, or does that already exist? Can you just tell us a little bit more about how that works?
Yeah, so the answer to that question is yes. So if you as an individual go and download the well-being index, you can self-assess, look at how your level of well-being compares to other people who are like you in terms of your professional group, and you can access or sort of get to national resources in a variety of different domains, and they're updated to be COVID related resources as well as non-COVID related resources. So it's more generic, but that's what's available for free for anybody really in the world. If an organization has a subscription, then they can sort of tailor the resources to be organizational specific, right? So if organization X has a subscription to it, they can populate local resources. So the individual could get both local resources as well as national resources. And the advantage of that is, if you're a nurse in Arizona, you could see the resources that are available for nurses in Arizona by Mayo Clinic, for example. It also has the backdoor advantage that the employer can sort of see, what kind of resources people are looking at, aggregate de-identified data in terms of, how are people scoring relative to people at other institutions, what professional group looks like it's having more trouble than other groups, so we could help pinpoint some strategies. But there's a cost to that because there's programming that's obviously involved in tailoring it to a specific, organization. So there's both.
Great.
We have another question on chat from Natalia. How was the transition to Zoom Compass meetings? Did clinicians keep signing up for it, and did new ones start?
I'm not sure I understand the question. Could you give me a little more background information about that? I mean, I think.
Sure, Natalia, do you want to go ahead and
Zoom or?
Yeah, this is Natalia. Can you hear me?
Yeah.
Oh, great. So I know a lot about the Compass program, and then in fact at Health Partners we had started something similar called the Connection Group, and we had started doing them for clinicians in person. And in fact, I was part of one of the developing of the pilot, and was part of one of the first ones. And I feel like through all of this, as we know, isolation has been an incredible source of stress for many team members. And as response, we would typically get together to debrief or do things, but we can't do that. And so we struggled on how to continue with our connection groups in this lay of the land. So I'm wondering if the Compass groups, I know that you've had a lot of experience with them, but how was the transition from the old-time Compass groups to the new normal Compass groups? Did people continue to sign up for them? Did new ones start? I feel like our clinicians are not very inclined to sign up to these Zoom get-togethers, so to speak.
Yeah, so we haven't yet done a big push to get new recruits. So the Compass groups are ones that have been existing, so people have established relationships. And I think that that's been helpful. People have sort of taken this in different ways. They have sort of their topic that they talk about, but some of the groups have sort of transitioned into a sort of more of a Jeopardy thing. So, they're doing trivia together or kind of various things as they're eating their meal. So one of the things with our Compass groups is most people sign up in groups. So, they have 10 of their friends and they want to do this together. So there's already kind of a natural cohesion to the members. We have a few groups where people have just raised their hand and said they want to be in a group. And then we bring them together, but they are harder to really grow and to continue than groups that have kind of naturally, organically came together and then want to use the Compass mechanism as a way to stay together and remain connected. But I think you're right. It's this, how do we sort of how do we create new connections in the current environment? And I think that's a huge challenge for all of us. And I really hope that some of you have solutions or ideas around how we could do that piece.
Thank you. And so I just want to oh, go ahead, Natalia.
No, thank you. I think one of the things that we've started trying at Health Partners is creating very specific areas and topics that are bringing people together in webinar formats, for example, some brief formats, and then people sign up for them. But again, I think we're all still getting used to these new ways of doing things, and we're learning, and there's not yet a lot of appetite, but interested in exploring more of how to build community, decrease isolation, which is going to be a big thing, especially in the winter here. but it's going to be a big thing moving forward for the next 1 to 2 years.
Yeah.
I just want to ask one last question. It's my favorite question for all our presenters, but in terms of feedback from staff. So you mentioned the quarantine, which I think was really interesting, how you learned that the stigma potentially for staff. How else has been the approach to get staff feedback to kind of do these cycles where you can figure out what to add, what to change? What's been helpful for you all?
Yeah, so some of it is is frankly utilization tracking. We spend quite a bit of time sort of tracking, hits to various programs, number of people signing up for connection groups, like for example, the number of people calling the warm line. So that's a piece of it, right? Because if you see those numbers keep going down and staying down, that sort of interest has waned, and either you need to do a campaign to push it out, or you need to sunset it and try something else. I think that's one of our biggest challenges, is how do we be more agile? We're not used to that. We build things, programs or whatever, and then we just continue them in perpetuity. And we're being more challenged to think about how to be more agile. It's not a failure that we had a warm line for 4 months and now we're sort of keeping it on the back burner until we feel like we need it again. That's just part of being an agile organization. The other tools that we're using, obviously, beyond the quarantine survey, really is for us our Facebook site. So that's another way to have a listening strategy, to sort of see what are the concerns and the interest in the activities that our employees are interested in. But we have to continue to think about, what are better and novel ways to keep our finger on the pulse, so that we can meet employees' needs going forward.
Fantastic. Thank you. Well, thank you so much, Dr. Dyrbye. I really appreciate you coming and sharing kind of the wealth of information. Please feel free to reach out to her for any questions or more information on the number of the initiatives. We look forward here at ICSE to continue conversations. As we always like to say, we like to create friendships here. So the goal is for us all to be friends and to be a network and to really not reinvent the wheel. So if somebody's doing something interesting, feel free to reach out to them and learn how to do it yourselves and bring it to your organization. So with that, we will see you in 2 weeks on a Thursday. We'll send out reminders, and take care, everybody.
Bye-bye.
Thank you.
Thanks a lot.